here today using the publication of the book as an opportunity to talk about the carnage of medical error and hospital-acquired infections, which are killing many Canadians needlessly. And you know, we put in the head of the media release that the equivalent at the outside, the equivalent of 3 jumbo jets are crashing every week with about 1,150 patients on them being killed by medical errors and hospital-acquired infections. And of those deaths, people think about 30% anyway are preventable. So you've got a huge loss of life happening. And if the jumbo jets were crashing, I think you could expect, you know, the federal government, the Ministry of Transportation, the Aeronautic Safety Board to be leaping into action, demanding that the skies be kept safe for air passengers. But you don't have anywhere near the level of concern or advocacy coming from the provincial government, which in this case has carriage for healthcare issues. And in fact, they tolerate systemic problems which underlie this death toll and perpetuate a problem which we could do something substantial about. So we're here today to talk about solutions. We're here today to talk about the systemic problems. And so Bill's going to talk a bit. I'm just going to come back to solutions, and then we're going to be open for questions, if that's okay.
Yeah, we want to discuss the philosophy of closing hospitals and closing beds, either in the province of Ontario, the country of Canada, or the U.S., to save money. It's a ridiculous paradigm. It makes absolutely no sense. If you do a real cost-benefit analysis on what medical errors and infections are costing Ontarians and the Ontario healthcare system, it makes no sense to start overcrowding the hospitals that exist, because that's one of the direct systemic causes of medical errors and infections. And if they were to do a real-time cost-benefit analysis, really apply scientific rigor to it, this would be untenable. It wouldn't make any sense at all. So we are trying to educate the public that these closures, these cutbacks, these budget cost savings that they call them are non-sustainable and will affect in a real-time way the health of the Ontarian people and the Canadian public. So that's one of the things that we really want to underline and not circumscribe to get across. The fact that 18% or almost 1 out of 5 Ontarian patients that enters a hospital is harmed, according to our statistics, is again non-sustainable. These medical errors, which are defined as medical error infections, misdiagnoses, thromboses, they all have either an effect on mortality, which basically means death, or morbidity, which means harm. And this type of harm could last you and change your quality of life. And the systemic causes of these errors are not being dealt with by the Ministry of Health or the governments, provincial governments in Canada or in the U.S. And they are factory medicine. Michael will talk a little bit about more in depth specifically for Ontario, where they're closing beds and reducing workforces and adding operations per hour or patients per doctor per minute, however they measure them, is a systemic cause of these errors. Ratios, when you don't have enough nurses per patient, doctors per patient, housekeepers per patient, we know that it's a direct link to medical errors and infections. In fact, all the systemic causes that we're going to talk about today have been in the scientific literature. They've known about this for decades, and they haven't done anything about it. And that's why we're at the scope and that we're at. That's why we've landed into an epidemic of harm, because for decades they've been ignoring these systemic causes. Shift work is another systemic cause. When you increase hours per shift, per day, per worker, you add a linkage, direct linkage to medical errors and infections. Accountability is another systemic cause. We can't get healthcare workers in the province of Ontario or Canada or the U.S. to wash their hands between patients, which is a direct linkage to these medical errors and these infections. The hospitals do not stand accountable to training their healthcare workers and making them and applying their policies and procedures. Again, this is not a worker problem, this is a systemic problem, that the systems are not accountable to their own policies and procedures. Studies have shown many, many times over that even doctors walking out of a bathroom do not wash their hands. And nurses don't wash their hands, and healthcare workers don't wash their hands between rooms or between patients. We're not cleaning hospitals properly. This is huge, given the fact that we have multiple drug-resistant strains now of a lot of different forms of infections, that we don't know how to clean a hospital, that we cannot get this right, that we don't clean the right surfaces, that we don't clean the right areas, that we don't know how to clean, that we don't test after cleaning so that we make sure that the cleaning is adequate, that we don't allow enough time for cleaning, and that we don't have enough cleaners, and that we're not training them at the level of risk. This is untenable in 2012 in any hospital in an advanced society, so-called advanced society. Training that doesn't come near the level of risk is another systemic cause. Legal issues that conflict with patient safety issues. When there's a medical error or a hospital-acquired infection and they want to do what we call a root cause analysis, which is an investigation, many times the white wall appears, and the white wall is very much like the blue wall in police work, where healthcare workers are told not to reveal, because by the legal representatives of the hospital or the facility, because it may lead to higher costs for litigation and higher punitive damages. They are just given a behavioral essence to keep quiet. And that's one of the real contradictions in getting to the bottom of anything, of any accountable legal issue that goes on with medical errors or infections. We don't have a reporting system that has any kind of scientific rigor. Hospitals in Ontario are not obligated to report these errors. Self-reporting is absolutely ridiculous. It has absolutely no scientific quality to it.
We should give them a bit of background on that.
Yeah, go ahead. Well, reporting, there's no province, with the exception of Quebec today in Canada, that has reporting regulations. So we don't have any real data. The data that comes out in Canada and in the U.S. is somewhat spurious. We have more research in the U.S. than you have in Canada. So we get a little bit of a better idea of what's going on. But the non-reporting rates in both the U.S. and in Canada are extremely high.
Reporting, you mean reporting incidents of...
Pardon?
Reporting what? Reporting...
Well, when there's a medical error
okay.
that affects a patient,
Okay.
or when there's a hospital-acquired infection,
Because
they're not obligated to report this.
They often report in, like when there's an outbreak of something at the hospital.
Sometimes they do, sometimes they don't.
Okay.
There is a voluntary reporting of hospital-acquired infections on the Ministry of Health website.
Okay.
The cases reported there bear no resemblance to the prevalence of the problem as reported by CIHI, for example, the Canadian Institute for studies because when institutions report, they tend to flatter themselves. That's what the science shows. They tend to repress information which would make them look bad. Not always. There are some organizations which approach this problem from a very scientific point of view, which is they've got a problem, they're going to deal with the problem, they're going to get to the root of it, they're going to solve it, and that includes being open about it. But that is actually, unfortunately, kind of rare.
There's no standardization across the country that obligates them to report in a methodological way, so that we don't know what they're reporting. There's no consequences for non-reporting. So if you don't have a scientific investigative reporting base, we don't know what the scope of the problem is. What we can do is extrapolate from the non-reporting studies that have been done, both in the U.S. and in Canada. And those, Leap was an author, L-E-A-P-E, who did some really good studies on this, and he says his calculations were between 5 to 20% of errors or infections are reported. That means 80% go unreported. So one of the things that we would like to ask for in terms of the solution to this is legislation obligating the province of Ontario to report. Quebec has a good reporting law. There are problems with it, certainly, but they've just actually come out with a 6-month report where they showed 179,000 adverse events in 6 months. So if you double that, that's over 350,000 for one province. And you multiply that by 10 provinces, and you get 3,500,000 adverse events.
The populations.
Pardon?
The populations don't work.
Yeah.
They're not on the equivalent sides,
But I mean, there are different ways to look at this.
Eastern Washington State.
Yeah, right. But you know, there needs to be a reporting regulation in Ontario that, with a methodology that they have to follow, because if they self-report, they can call something a medical error and something else not a medical error. They can call something an infection or not an infection. In the U.S., we have 27 states that have reporting regulations, but they're very weak. And some hospitals, we had a report in the Seattle Times not so long ago where, in order to avoid reporting a medical error death, they kept they have to report within 24 hours. Within 48 hours, if a patient comes in, if they're harmed by the hospital, they have to report within 48 hours. If they did that harm within 48 hours. So what they did is they put the patient on a breathing machine. They kept them alive for longer than 48 hours, medically alive, but clinically dead. And so they didn't have to report it. That's what we're up against. So there needs to be some real rigor in terms of regulation, making these healthcare services and systems report if they make a mistake.
It's a feature of recent outbreaks in Ontario, for example, in Burlington at Joe Brand and at the Niagara Health System. It's a feature of both of those outbreaks that the hospital administration deliberately withheld from the public information about the extent of the outbreak. And one of our points is, if you have to take your parents in for surgery, they should be forthright with you. They should tell you, sorry, we've got an outbreak of C. difficile, we just lost 40 patients here. Maybe you should go to Hamilton Health Sciences. Maybe you should go to a Toronto hospital. But they didn't do that. They suppressed it until the extent of it was so large that it couldn't be suppressed anymore. And then the province responds by sending in a supervisor, even though what happened in both of those cases was pretty much identical to what had happened in Montreal, in Winnipeg, and in Nanaimo, BC. Similar outbreaks, similar root causes, right? But you can't rely upon people to voluntarily report information that they think is prejudicial to their own organizations. The recent history, which is anecdotal, but would suggest it just firms up the science, which is when you actually look at the charts, when independent observers, clinical observers look at the charts for institutions which have reported, they find, oh my gosh, they underreported by 80%. Yeah. Why? Because it makes them look bad. It makes the doctors look bad. So everybody sort of hushes it up. This is a problem we have.
Right. We have a website in Seattle, Washington State, where I'm working presently, where hospitals will self-report their infection rates. And every single hospital, ironically, in the city of Seattle, large hospitals, nobody has an infection rate over 2%. Now that just does not coincide with any of the science. And that's self-reporting because it's exactly what Michael's saying. They don't want to look bad. They're a consumer organization. So if they have a high infection rate, they're going to get less consumers. In the U.S., more and more states don't even call patients patients. They call them clients. And we have a for-profit system, and for-profit hospitals have 2 to 4 times the rate of medical errors as non-for-profit. Here you have factory medicine. And the last systemic problem that we talked a little bit about earlier
Just
was
on factory medicine.
Pardon?
Factory medicine.
Yeah.
In our context, that would be a province that has cut 18,500 hospital beds in the last 15 years, so is now operating at 98.5% occupancy, even though the science would suggest that anything over 82% occupancy is a problem for the transmission of hospital-acquired infections. And the countries that have actually brought the rates down, the Netherlands, Scotland, etc., not a country yet, but still it would like to be, where they've been proactive, they have occupancy rates under 82%. Factory medicine is pumping, we have the shortest lengths of stays, the fewest beds per population, fewest staff for those beds. We just pump people through our system as quickly as we can, and that's how the system is judged. How long did you wait? How long did it take you for service? The fact that 18% of you going through that system will have an adverse impact. Like, you wouldn't tolerate that for your car. Every 5th visit to the dealership, it broke down on the way out, or the engine blew up. You wouldn't accept that. But that's the consequence of factory medicine, right? We have a volume that's so challenging for the system that it can't cope. I just wanted to put it in our
it's great.
context.
It's great. I mean, it's good that you explain this. I mean, it's yeah.
Well, I'm just wondering how much of a factor, if this can be defined, a patient going into a hospital that may have some kind of ailment that has been undiagnosed prior to being in hospital, may subsequently die and have it blamed on, I'm sure it's hard to judge the figures on that, but is there...
Well, some are, and that's what we want clarified. I mean, these things really need to have an independent analysis. I mean, there are also patients that acquire a hospital infection. They don't die in the hospital, but then they go home and die. How do we count those? This is the kind of scientific rigor that the Ministry of Health needs to bring to this task, so that we can get these real numbers. Without these real analysis, we don't know how to create the solutions. We just go around and around and around, and what's happening now is it's going around so fast that we have an epidemic of harm.
So is the Ministry of Health not recording these numbers? Like, for instance, I should say if somebody dies at home from a hospital-acquired infection, there is no record of that.
That's
No,
correct.
and they don't track readmission rates. So if they part of the way that they judge the efficiency of the system is how quickly they move you through it. It's long been a criticism of that approach, that it results, particularly for the older patients, in them being sent home prematurely and then coming back, presenting with, a problem again. So they were sent home before they should have been. Now they're in worse shape than when they left. They don't track the readmissions because that would reflect badly on the whole stream of the process, right? So.
We have done some preliminary statistical work because Canada and Ontario haven't done it. And the union has been painstakingly trying to get to the root of some of these numbers. And it's very difficult. And we have ranges and we take medians. But, you have bureaucrats in Ottawa who are deciding who's going to live and who's going to die, because they don't do a rigid cost-benefit analysis about what the healthcare system is doing. They're kicking the can down the road in so many different ways in terms of cost. I mean, if you want to, in terms of the factory medicine paradigm, kick people back into the community as soon as you can, so that the bill doesn't come to the Ministry of Health, but it's going to go somewhere else. That bill has to be paid. Maybe the family has to pay it. Maybe the family can't pay it and they have to go on social assistance. So you're kicking it into the community. I mean, we're all in this together. And that's what they're not figuring it out. That's what they're not figuring out in terms of a cost-benefit analysis science. I mean, there's no rigorous analysis on what we've figured out that there's about approximately $7 billion that these medical errors are costing in Canada. So if you divide that $7 billion by the number of beds in Canada, which is I think approximately 70,000, you get about $100,000 per bed before anybody lies in it. That's what it costs to put that bed in that ward. Now that's a very, very rough number. It's a very large and unscientific way of doing this because we're working with numbers that we don't know how real they are. But when we do like what we call a macro analysis, that's the way it comes out.
What did you
And then
say?
they want to say they're going to save money by
Seven-
closing hospitals?
Sorry.
7 million per,
The
per
7
year?
billion.
Society of
7 billion?
Society of Actuaries estimates the cost of medical errors at being $7 billion
For what? For a year or for?
for 1 year for
Okay.
Canada. But that's based on numbers that we're arguing significantly underreport the problem because they're the official numbers. So, but that being said, divided by the number of beds in Canada, that would be the equivalent of $100,000 per bed is the cost of medical errors. Or in Ontario's case, that would be,
Is that because the people have to
2.8
stay in the
billion.
hospital longer, or they?
Pardon?
Where's the cost come from? If they're dead, then they don't have to pay.
Yeah, the costs come, when you have a medical error,
Uh-huh.
you have to treat that
Okay,
patient. So
because they're
increased
being
patient
treated
days,
longer, okay.
increased medication costs.
MRSA, for example, you get MRSA in the hospital, you've got a likelihood of a 15-day stay. Some of that in intensive care at a cost of maybe $3,000 a day. The rest in the general hospital population at a cost of over $1,500 a day. So the cost of treating a MRSA patient,
About $15,000 per patient in Ontario.
Okay.
Bed sore.
to give you an example.
Bed sore. We have, the Society of Actuary reports. If you go through these numbers, which we've done, $10,000 per bed sore. So calculate the number of bed sores in the province of Ontario, then divide that by what it would cost to hire an orderly to turn that patient 2 hours, every 2 hours. And the cost benefit was you could pay for all the numbers of orderlies, save money by reducing the bed sores.
So just to wrap up,
Yeah.
because you're going to have questions and we can talk to you all day. So we're asking the Ministry of Health in Ontario take this problem seriously. When we look at other jurisdictions, and we mentioned the Netherlands and Scotland a little earlier. In Scotland, for example, they've got their program on hospital-acquired infections is called Search and Destroy. They've dropped their death rates down by 50% for diseases like C. difficile because they're proactive and they're aggressive. They have a plan. The only plan that we've heard of from our ministry is wash your hands. And as Bill mentioned, there's some problems with getting that actually done. But the problem around hospital-acquired infection is much bigger. So we're asking the ministry to step up to the plate. We're asking them to require healthcare institutions to report through legislation their medical errors and outbreaks of hospital-acquired infections. And we're asking them to take a serious look at the kind of staffing ratio legislation that states like California have put in place, which deal with the problem that as the number of patients per nurse, for example, grows, the likelihood and the actuality of medical errors grows with it. And I think what we go from 1 to 4 to 1 to 5, we go up 7%.
7% in mortality. That means you have a 7% higher probability that patient will die.
You go up another one?
31%.
So to go up to 1 to 6, I bet if you go to the Cobourg, the Northumberland Hills Hospital now, and ask them what the real ratio is of nurses, RPNs, and RNs to patients, you might be surprised. And certainly in long-term care, to go back to the bed sores problem, right, and other problems, there's serious staffing issues which
This is the
go to
problem.
quality of life.
This is the myopia. They are trying to save money by cutting staff, and they're spending much more money because they're creating disease and error when they do it. That's what they're not getting. That's why the ratios, that's why it needs to be legislated.
So we could try to answer any questions.
So that's the main purpose of your tour right now, is to try and get the ministry to listen to your...
Yes, we're trying to draw attention to the scope of the problem. We have a conference coming up June 4th with people coming from across the United States, Quebec, and Canada, and we're hoping that we can get some attention. There's been a fair bit of attention in Ontario around hospital-acquired infections, none really around medical errors, which is another whole layer of the problem. Yeah, so we're trying to get some attention.
Raise the level of awareness in the population. I mean, if you know that you're going to go, every time you interact with the healthcare system in Ontario, there's a 1 in 5 chance, or even higher, that you're going to be harmed, people will begin to demand that something be done about it. They don't know. The populations in the United States, in the U.S., it's the leading cause of death. Here in Canada, we suspect that it's the second leading cause of death.
Where do you get that figure, 1 in 5?
The studies.
Studies? What's...
Different sources.
18%. I think it's in your.
It's in our book?
It's in your.
Okay.
18% is what we calculated in Canada,
Okay.
but that's not including the non-reporting rates. In the U.S., there was a study in Health Affairs, okay, which is a prestigious international journal, and they say in the U.S. it's 1 out of 3 patients that enters a healthcare facility in the U.S. will be harmed. I mean, you can extrapolate these to Canada. I mean, Canadian hospitals are not any better or any worse.
Well, except that we have a different kind of system.
Pardon?
I mean, in the States they work for profit, and in
Yeah, but you
Canada-
still have the same systemic problems.
Yeah.
I mean, we went through them, you know. You
Yeah.
still have the same 10 or 11 systemic problems. Your ratios aren't good, your shift works aren't good, your cleaning isn't good, I mean, on and on.
So why are you bringing up this now? Is there a particular reason for?
Yeah, because it's become an epidemic.
Because it's become...
Well, it's not. I mean, we had a portable hospital room set on the road. We were in Cobourg here last year. We've had a 7-year campaign around hospital-acquired infections. So we
Okay, so it's been ongoing.
Oh yeah.
Yeah.
No, we've been. We have a law firm that's drafting legislation requiring hospitals to report medical errors and hospital-acquired infections. Will be coming back to Cobourg to talk about that in the fall. It's not an issue that we plan to let go, but we've been campaigning continuously for 7 years now on this particular issue.
The things I've been hearing from like Dalton McGuinty or the provincial government is that they've actually like reduced waiting times and they've improved, increased beds. I'm not sure. I don't know all the numbers, but I'm sure that's what they would tell me.
The federal government gave the provinces money to reduce wait times in certain areas like cataracts, hips and knees, cancer care, and you will find that wait times have dropped because resources went to hospitals to reduce wait times for those purposes. You will also find that wait times for some other procedures have lengthened because, of course, there's a fixed supply of radiologists, surgeons, nurses, etc., who are now fixed in the priority areas as defined by the federal government: cataracts, hips and knees, cancer care, right? So for other types of procedures, the wait times may not have actually been reduced. Ontario has cut 18,500 hospital beds in the last 15 years.
Okay, so they would argue though that they've increased the beds. I don't know.
No, that's not true. Not acute care beds, no.
Okay.
They might have increased the number of long-term care beds, but acute care beds, like look at Port Hope, Cobourg. This happened from the Harris government forward, right? You had 2 hospitals, you now have 1. Peterborough had 2 hospitals, you now have 1, right? And so
But do we know that the number of beds has decreased?
Not only did you lose hospitals, the number of beds within the hospital has been being reduced systematically. So I'm sure if you went back to the report of the Hospital Restructuring Commission, we might even be able to get you that information and looked at what was in place when you had the 2 hospitals to what you have up and running today. You will notice a marked decrease despite the fact that your population has increased and it has aged. And as it ages, it presents at the hospital doorstep for obvious reasons, demanding more services. They have heart attacks, strokes, knees have gone, whatever. So there has been a huge drop in our capacity while the population aged and increased. And as a result, Ontario has a system operating, we have the fewest hospital beds, acute hospital beds of any country with a developed economy in the OECD, including Mexico. No country has fewer hospital beds to population than Ontario does. We have the fewest in Canada, and Canada has the fewest in the OECD. So we haven't added beds. What we've done is we're pushing people through more quickly, but as a consequence of pushing them through more quickly, mistakes get made. That's part of the problem. You can't have physicians working, interns, residents working 36 hours without sleep, not making mistakes in the ER or in, you can't have nurses working 12-hour shifts, which they do routinely, to meet the demands here. And on the last 4 hours of those shifts, the error rates increase for the nurses because they're just so tired. I mean, these are the consequences of a system that's stressed.
And they're cutting support staff across the province. And cleaning, for example, is labor intensive. And there's been, I think 3 to 5% cut in the last year or last 2 years in support staff services in Ontario. So you can't cut these positions and then expect that you're going to get less infections. I mean, in Ontario, it's 17.9 patients per 100 acquire C. diff. So, I mean, that's a crazy system. It's a system that's creating disease, not preventing it.
To go back to your bed thing question, the government also plans then to reduce out of the hospitals the alternate level of care beds, the respite beds, the rehab beds, and the psych beds, the so-called non-acute beds. So we're expecting another 5,000 or so beds to be cut out of the system over the next few years. We're anticipating a further downsizing, and that's going to create its own other series of problems. Right. But I don't buy. No, the Bagitti government has not added beds. They've cut beds.
Yeah, I'm just sure that that's what they're going to tell me when I go and ask them.
For sure.
Listen, they're boasting about it. I mean, you could call them. They're boasting about these cuts.
Yeah.
They're not hiding them.
To save money.
Yeah, but and that's exactly what we want
Taxes,
reported.
yeah.
You cannot save money this way if you count what you're creating in terms of medical errors and hospital-acquired infections. That is really throwing good money after bad. It makes no cost-benefit sense. And I don't think they have anybody in the Ministry of Health that really knows how to do a cost-benefit analysis. I would challenge them to stand in front of me right now and try and do it. They can't do it. I've been with CEOs, CFOs, Harvard-trained MBAs, and they don't understand the cost of injuries either to the workers or to the patients. And here's the other loop that they don't understand is when you harm a worker, you harm a patient. When you harm a patient, there's a possibility of harming a worker. They don't get that interconnection.
Now, have you come up with any figures as to how much the changes that you're proposing would cost?
The proposals would cost?
Yeah.
No, because we're at a stage where we have to persuade the government to report to get valid numbers, right? Let alone all the costing, all the estimates around the costings, that the $7 billion that it costs the system for medical errors are based upon under-reporting by institutions, right? So the scientific studies would suggest institutions are under-reporting by about 80%. So the actual, but we're not going to multiply the number we gave you, the $7 billion, by the number that would turn that into a more accurate number. Just on that number alone, you could go a long way to dealing with many of the problems. For example, in the bed sore problem, right? The single reason that people have bed sores is because they're not turned. They're immobile. They've had a stroke. They can't turn themselves, and their bones, irritate their skin when in contact with a mattress. If they're turned every 2 hours, they don't get bed sores. If their skin breaks open, then they have excruciating pain, and these are difficult to heal. It's a single leading medical error, and it could be solved by simply having people turn people in bed. Surely that would be something that we could manage. What would that save relative to the cost of treating a bed sore with antibiotics? And we would argue it would probably be cheaper. Prove that scientifically? Well, we can't do that because we don't have accurate numbers, because people don't report.
Yeah, it's a hard paradigm, and that's why the ethical argument. It's not a cost argument. In California, they added, since the implementation of the ratio bill, it was implemented in 1999, and it was a phased-in bill. So by 2005, every aspect of the bill for ratios had to be effective by the healthcare facilities in California. They've added, probably in the last 3 or 4 years, 90,000 nurses to comply with the bill. If you look at it strictly from a cost-benefit analysis, you probably could prove that saved the state of California money if you looked at what they were paying for the injuries caused by medical errors and infections. That's probably a very good, cogent financial argument. But the ethical argument is much stronger. And why safety in North America becomes a cost-benefit argument rather than an ethical argument, I've been struggling with for the last 30 years. I don't understand it. It's the ethics. If your father and mother go into that facility, you don't want them harmed. And you're not going to put a price tag on it. We don't do that in North America. We're supposed to be an advanced society. It should not be a numbers game, and it shouldn't be a money game. It should be a game that's driven by the science. The science for the last 2 decades, study after study after study, shows the 10 systemic causes that I outlined here for you today create medical error. They should do something about it. Point final. That's it. The bureaucrats sitting in the room should just do it because it's the ethical thing to do. Not because it's going to save money or cost money. It should just be done because that's what the science says is the safest way to do it. That's the paradigm they should follow. And when they say they don't have the money to pay for it, it's nonsense. If you look at what it's called, what's being paid for on the other end, no matter which department in the ministry or the province is paying for it, you got to add it up. It's oranges to oranges. The dollars are being paid for those errors and those infections by some department. Believe me.
And on that note,
I got a headache.
yes,
Thank you
thanks so
very
much for coming.
Thanks for coming.
We're dealing here, though, with a specific demographic in terms of a hospital-acquired injury, or are we dealing more with the frail population as opposed to a younger population, a senior population as opposed to?
No, you're just dealing with an immunocompromised population. You could be a young child. If you are in a hospital and for some reason you're in the hospital because you're immunocompromised, because something's... Most diseases are immunocompromised diseases.
But generally speaking,
Yeah.
your older population would be more susceptible for that reason. Right?
I think if you... Probably for mortality, yes. For morbidity, I don't think so.
But for somebody who goes in, who is, in generally good health, who has an emergency or traumatic event, then it would be less of an impact than somebody in their 80s and somebody in their 80s who's...
No. They have to be intubated or catheterized, or they have IV lines in them, depending on what they were operated on for. Those are all open, and all can be potential infection sources, sites for infections. And depending on the capacity of the hospital to prevent transmission, that's what's going to either create an infection, hospital acquired, or not. And if you don't know how to wash your hands, or if you're touching surfaces that haven't been cleaned, even if you're wearing gloves, and then you touch that IV line, or you touch the catheter, or we measured mercury on electrode lines on EKG machines. The stethoscopes, blood pressure cuffs, they're not cleaned. Once a healthcare worker touches that and then goes and touches an IV line, boom, you've got transmission. Whether you got gloves on or you don't have gloves on. So there's different realities and levels of cleaning that need to be done in order to protect that patient, either in the OR, in a step-down unit, in an ICU, you know, in a recovery ward, in an ER, so that they're not, they don't get the bug.
Can we answer your question?
Yes.
Do we? Sometimes I
was just wondering, how do you, you were mentioning earlier that doctors and nurses and healthcare workers don't wash their hands. I mean, how do you persuade, convince, or
Well, the rates,
the
rates vary.
How do you? It's almost like, how do you deal with that? You can't really. If somebody just doesn't wash his hands, he doesn't wash his hands.
This is
Doctors are the worst. Doctors are the worst.
This is why Michael raised the question of like 2 or 3 jumbo jets going down.
Mm-hmm.
I mean, if the NTSB heard about that, they would solve it. Every healthcare administrator in this province and in this country and in the U.S. knows these studies. And they don't do anything about it. They don't test for it. They don't require it. There's no consequences. I was in a hospital in Seattle with a friend of mine, and I spent 3 days. And they, I won't mention the hospital, but they broke every single infection control regulation you could possibly think of while I was there.
Why don't people wash their hands? I mean, the performance rates can be tracked by institution. You can get them for the Northumberland Hills Hospital. And they can be from 40% of healthcare workers are washing their hands to 90%. It really varies. But why don't people wash their hands? I think generally it would be because they're so frenzied. They're short-staffed. There's no coverage when people are sick. So if somebody's sick, which happens, then you've got their load on top of your own. You're racing from patient to patient. You're trying to get everything done, and you don't remember.
Or the not enough sinks.
Yes,
Structurally in the
not a
hospital.
problem here because it's a new hospital, but that was a case in Montreal where the one of the coroner's findings was that yes, and I think that was Niagara Health System too in the older hospitals. There weren't sinks in every room, so how do you wash your hands? Well, you use the alcohol gel, but unless you work it in for half a minute, it doesn't work, and it doesn't work for C. difficile. It doesn't kill those spores. So just because those are available doesn't mean that you've solved the problem, right? So.
But imagine you're an administrator in a hospital and you're not fired because your staff isn't washing your hands. It's the bureaucracy in these institutions that have gotten into such bad habits of accepting these kinds of numbers. I mean, not washing your hands in a healthcare facility is like a pilot coming in drunk.
The other thing is you have to have a kind of a holistic approach. To be taken seriously by the workforce, we'd also have to be saying, okay, we have a 5-step program for eliminating these acquired infections. We're all going to wash our hands, and we're going to shadow you right through the day, and we're going to remind you every time, and we're going to take you to visit some people who have MRSA or whatever. We're going to review all of our cleaning protocols. We're adding resources for cleaning. We're stepping up infection control. Meet Ms. Craddock. She's the infection control specialist we brought in. We're going to do all these things. We have a holistic approach to deal with this. But a lot of the emphasis is simply on posting signs, please wash your hands. And it's not, that's not
Complied
not
with.
going to do.
They don't comply, and there's they don't report. Healthcare workers won't report on other healthcare workers. Nurses won't report on doctors. Doctors, there's a chain, there's a hierarchy, and there's a white wall.
Because of malpractice suits. Yeah. So, that was cheery, eh?
Yeah.